Welcome to you to this new podcast, Equity Bridges. I'm extremely happy today because we have two great colleagues who will talk with us during the next 15 to 20 minutes. I will start with a short presentation about the two of them. You know one of them because he had an intervention before in another podcast. But our first key speaker is Tamara Giles-Vernick. She works at the Institut Pasteur at the Department of Global Health Anthropology and Ecology of Disease Emergence Unit. And she is, in terms of background, Doctor of Philosophy. So it's great to have you today, Tamara, to have this interaction concerning a very interesting and European program. So welcome, Tamara. And the second key speaker is David Napier, Professor of Anthropology at the University College of London. And we had the opportunity to listen to you, David, a few months ago with the first podcast. So you're more than welcome too, David. Thank you. Today, I would like to start saying thank you to the European Commission because we have a very important partnership between the Sonar-Global European program and Unisanté. And for this last podcast of the thematic series of podcasts concerning health equity and COVID-19, the idea is to present the role of social science, and Sonar-Global in particular, for the management and for the evaluation of infectious threats and their part in the answer of health authorities in a pandemic. And of course, because of the COVID-19 pandemic, it's completely appropriate to take a moment to think about that. So I have 5 questions for you, for both of you, and I would like to start, Tamara, asking you about Could you tell us a little bit more about this Sonar-Global European program? What kind of network, what kind of goals of organization, and of course the relevance of social science and the COVID-19 pandemic?
Right. Thanks, Patrick, for the invitation to be here. It's a pleasure. So Sonar-Global is a consortium made up of 15 partners, and we've been tasked since 2019 to create a global network of social sciences for preparedness and response to epidemics and to antimicrobial resistance. So since the beginning, we have focused on certain aspects of, for instance, capacity building within the social sciences, particularly because in many institutions around the world, social scientists dealing with epidemics in AMR tend to be isolated and may not be as well integrated into epidemic preparedness and response or AMR as they could be. So one of the aspects of our work has really been to reinforce the capacities of those social scientists, as well as reinforcing the capacities of, for instance, clinicians, epidemic responders, biomedical researchers, to work more effectively with social scientists. We've also been deeply involved in developing tools and models, and I think that's probably why David and I are here today. That is specifically tools to understand better the complex and interacting and dynamic factors that marginalize or exclude particular groups of people and render them in effect less capable of coping with crisis situations that would impact negatively on their health. And then to take the insights that we've developed from those tools and work with authorities, other kinds of actors to, in effect, translate the insights that we develop into policy recommendations and policy actions that can really shore up particular groups who have been, for instance, denied access to healthcare or have been excluded in a multitude of ways. I don't know, just to say a little bit about our partners very briefly. Several of them are within Europe because, of course, this is a European Commission funded network, but we also have partners in West Africa, in Central Africa, in South and Southeast Asia, and we have over 800 members around the world, as well as about 20 different networks that belong to this large umbrella called Sonar-Global.
Excellent. Thank you, Tamara. It's very precise and, of course, an amazing network, this Sonar-Global network. A second question is more oriented to the vulnerabilities and mainly the social vulnerabilities. And maybe I can ask to you, David, to say a little bit more about that. The question is, how was Sonar-Global able to basically identify social vulnerabilities during the pandemic context?
Thank you, Patrick. I think, first of all, it's important to point out that we were able to do this principally because the European Union itself was able to respond quickly to the pandemic and to take an existing network that was already designed to examine health vulnerabilities and to come up with strategies for applying social science knowledge in those domains to the emergence of COVID-19. In fact, what we did do was we established strong relationships for a final work package in our grant agreement with the European Union, and within that context, we worked with 7 countries, including you in Switzerland and Denmark, but 5 additional countries in which we carried out vulnerability assessments, and those countries included Germany, France, Italy, Malta, Slovenia. And in addition to countries we had already worked in, principally with respect to the assessment, Bangladesh and also Uganda first, in fact. And indeed, we established relations, as Tamara pointed out, with colleagues in other regions, for example, the Ukraine and elsewhere, where for various reasons, in Ukraine's case, obvious reasons, we haven't been able to move forward that quite in the way that we would have liked to. But to the point of what the experience actually allowed us to do, I think it's important for us to realize that understanding vulnerability means understanding what happens in specific contexts in times of crisis, when oftentimes resources become scarce. People's concepts of community may actually become more stringent, when there are only so many resources to go around. And what happens to people who are living lives on the edge, perhaps barely getting along when a crisis occurs, and their additional risk factors push them to the point where they become their ability to behave in social behavior change or personal behavior change becomes quite limited, and at times might be eliminated within the framework of what we oftentimes refer to as structural violence. That is to say, there's so many things going on in a given setting, so many risk factors that can't be controlled, that a person becomes incapable of exercising their health agency. And so the idea behind the assessments very quickly is to look at 3 domains, principally the formal domain, that is to say that what services are available and how people use them, who doesn't, whether the outcomes are short or long term, who gets served and who doesn't, so forth. But then to move into the community domain, where we're looking at issues of social capital. Who are advocates? Who are the stakeholders? How do we engage them? How do we engage in the co-production of knowledge with those stakeholders? How do they change over time as a crisis evolves and transforms? In other words, we try to build up allegiances and alliances with those groups that indeed we intend to carry on beyond the crisis context, so that we can focus for the future on being better prepared, on being justly prepared, rather than only justly responding to a crisis once it happens. But the third, and perhaps from the standpoint of social sciences, most important or unique part about this, important insofar as it is specific to social sciences, is that we recognize that because people can become virtually invisible either by these compounding factors or by processes of social exclusion. We can all name lots of those in COVID-19 in retrospect, and we don't need to revisit what happened to particular groups when they virtually became invisible. Is that as ethnographers, we go out and we actually recognize the fact that people can't necessarily represent themselves. So we have to find those groups. We have to identify them. We have to identify what the barriers are that prohibit them from becoming agents in that particular setting. So rather than basing our assumptions upon what we believe to be the case, we try to determine what are the tipping points that allow people to regain agency. And I think that's really what has allowed us to allowed the Sonar-Global network to thrive within the framework of the European Commission opportunity that was offered to us.
Thank you very much, David, for the many details that you brought in your answer. That's really interesting. Now, you mentioned both many different partners, many different countries, many different topics related with vulnerabilities and invisible communities. Tamara, what do you consider today that are the main findings of this Sonar-Global project? Basically, what is for you particularly relevant for health authorities when they have to manage future pandemics? Especially if you think about health equity, do you have some concrete, some national examples?
Yes, although one of the, I would sort of preface my remarks with that these vulnerability assessments are highly detailed. Now, I've been doing ethnographic work for several decades now, and I have to say this particular tool that was actually, in fact, developed by David Napier and Anna Volkmann is probably by far the most detailed interview guide that I've ever put my hands on. So that some of these interviews could last more than 3 hours and were really incredibly rich. We ended up in Europe alone, that is in 5 countries, conducting 753 of them. So effectively what we're sitting on is just a mountain of qualitative evidence, which renders, okay, you know, what are sort of some of the high level findings that we can extract from this, a bit challenging to express. I think one of the points that really came out very clearly, though, was that there were certain kinds of institutional responses that could massively undercut the agencies, that is, the capacity of particular groups of people to act, of already fragile individuals. So that, for instance, in Slovenia, one of the things that our partners found there was that residential institutions were in fact a hotspot for infection, because of worsened conditions, lack of professional staff, lack of funding, lack of quality care. And so that these institutions responded in 2 sort of diametrically opposed ways. On one hand, they either locked up residents and in effect facilitated that transmission and basically closed everything off to outside context, or they engaged in massive kind of ad hoc release of residents and inmates from institutions without providing support for them. So there was, for instance, a mass release of prisoners in Slovenia, and other kinds of detention centers, and with basically, okay, well, come back when the situation improves. And these people were in effect left on their own without any kind of support whatsoever. In France, we also saw, for instance, the major closures of different kinds of agencies providing support for migrants, for asylum seekers. And even after those agencies had been closed, or opened up again, there was a major slowdown in activities, which had rendered, for instance, asylum seekers even more destabilized and uncertain than they would otherwise have been. In the educational sector, we saw both teachers and students left adrift, abandoning, for instance, courses of studies and the like. So that's one of the examples in which institutions that are designed to assist particular groups of people, some of whom are already marginalized, in fact, acted in such a way as to increasingly marginalize and increasingly exclude those populations. Another point, so none of that I think is surprising, but it deserves to be pointed out that this was a commonality across many of the countries that we found. Another has to do with stigmatizing discourses that often came from the state or other kinds of minorities. Again, to cite the example of Slovenia, this myth of the contagious migrant, so that asylum seekers arriving in Slovenia were in fact closed, confined for anywhere from 3 days and the like, and in fact facilitated transmission among those people, as well as all kinds of fear and anxiety. In Malta, another example is the declaration of a legal category of vulnerable people at the beginning of the pandemic. That is, certain categories of people were required to isolate themselves, with, of course, sort of the consequence of particular groups feeling stigmatized, feeling unsupported, and eventually the state had to rescind that legal category. And of course, it incited real antipathy towards migrants. So those are just a couple of examples. I don't know whether you want me to continue. There are a number of other points that I would just signal clearly that the factors that shape vulnerabilities are, as David suggested, and as our many studies pointed out, multidimensional, complex, and interacting, and ones that were not just epidemiological, but social and cultural. Many of our participants had pre-existing vulnerabilities that were in fact worsened over the course of the pandemic.
That's very concrete, Tamara. Thank you very much. I think you brought very concrete examples where we can see the added value of definitely social science in this approach. And my next question, and I think it's for, of course, both of you, is after Sonar-Global findings, what are, from your point of view, this added value of social science in the management, but also in the evaluation of COVID-19 pandemic, but maybe of the next future pandemics, concerning always, focused always on health equity? So maybe, I don't know, Tamara, you want to start, and after David can add some comments. Tamara?
Sure. I think one of, and we especially saw this in interacting with both authorities and different kinds of non-governmental actors in France. And that's where most of my sort of concrete on the ground interactions have been around this vulnerability assessment. And one of the things that these different kinds of stakeholders said was, look, we get the numbers. We have the numbers, but we don't actually understand how it is that people ended up in these situations and the particular policies or lack thereof that rendered them less able to cope with the multifarious challenges posed by an ongoing pandemic. And I think one of the contributions that we have made, both in France as well as in other countries, is really kind of enriching understandings about the range of experiences and the power of stories to show how it is that certain people end up in or pass through certain kinds of circumstances that are exceedingly difficult, as well as the factors that in fact reinforce their capacity to cope with these challenges. So that's where I think particularly the qualitative social sciences can really add to our understandings of how people may be affected by pandemics. David, maybe you want to jump in here.
Sure. I agree with absolutely everything that you said, Tamara. I think that having given this some thought as we reach the end of this phase of our research, is that one thing that has struck me very profoundly, I don't know, but it's really struck me, is the extent to which how dynamic societies are. And your point about responses, social responses, creating new vulnerabilities is something that as we recognize how dynamic societies are, we can prepare for these. For example, the mental health challenges that are emerging now, especially among young children, which will be with them for some time into the future, are things that we may well have considered had we been more engaged in thinking about the social determinants of health and all policies as it relates to epidemic outbreaks. And I think that our social science findings have made this very, very clear at the level of, to get to the point, Patrick, your point about health equity, that while these social determinants are incredibly important, also at the foundation of those are these social processes of trust and mistrust, inclusion and exclusion, the presence of agency, the absence of agency, and these all impact equity so much so that we know that we need to understand these more basic processes in society if we're going to be able to prepare more justly. And I only want to say that I think that this is a wonderful moment for us, because a lot of people are now thinking about these inclusion and exclusionary processes, including the Economist, which will launch next month, its Health Inclusivity Index, which will particularly actually do what we've been trying to do, which is to add numbers to indicators on cultural competency, on communities of care, and specifically on community engagement, which is something that Sonar-Global is working directly to apply our assessment strategies to enhancing, so that we are a more embedded part of the communities that themselves may at some future point become vulnerable.
Thank you, David. My final question is for you, Tamara. And the idea is to know a little bit more about what are your suggestions for the future of social science in the prevention and in the response to a pandemic. What is the perspective of the future if you think about all that you mentioned in terms of experiences, outcomes, results from this amazing international network?
That's a big question, Patrick, and I'm not sure I have quite the concise answer for that. I think one of the things that we've seen is that policymaking during pandemics has been very strongly driven by epidemiology and by modeling. And those are important contributions. So I'm not suggesting that, that those be discarded. But I also think that the social sciences has a role in trying to understand the differential effects that measures to prepare for and to respond to epidemics has on diverse groups of people. Many have in the social sciences have, been crying out, one size does not fit all. And in fact, I think one of the things that the vulnerability assessment shows is that measures that can be put into place to control transmission may inadvertently have really negative impacts on certain kinds of populations. And so we need, I think, a much more nuanced approach to pandemic preparedness and to pandemic response to really capture a better understanding of this differential impact, and particularly on marginalized and excluded populations. Two other very quick points that I want to make. I hear a lot of discussion about preparedness and a lot of discussion about pandemic response, but very little these days about recovery. And if we're going to be looking at additional epidemics, either large scale or small scale in the future, we do need to pay attention to questions of recovery, because there were, as I said, in our vulnerability assessment, we found people who were already fragilized, who were increasingly marginalized, and people who may have been doing okay during what the epidemiologists call peacetime, who were driven into more vulnerable situations during the pandemic. If we don't address these problems of recovery, then I think that we're effectively continuing those situations of marginalization and exclusion. And finally, one last rapid point. Sonar-Global is continuing under the rubric of the Isidore European Commission funded research infrastructure, which is also designed as a kind of multi-dimensional, multidisciplinary approach to pandemic preparedness or epidemic preparedness and response. So some of these services, some of these approaches that we talk about, users can actually get access to them by applying to Isidore and requesting our services. And we can do anything from developing protocols to doing trainings, and users can get those services for free. So that's something that might be of interest to listeners.
Sure. Thank you very much, Tamara, for this invitation. It's very clear what you mentioned just before. And I would like to thank you to both of you, because it was a very nice interaction concerning this European Commission partnership and international network, the Sonar-Global project. I was delighted to listen to you concerning the importance of social science, of course. And as always, it's a pleasure to listen to you about all that you can mention. So congratulations for this very huge and important effort, and thank you very much for your participation.